Hello everyone. I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. So in this particular session, I will be discussing a very important topic, that is the pleural effusion. So first of all, let me discuss the basics. In between the parietal pleura and as well as the visceral pleura, you have the presence of the pleural fluid. And what is the function of this particular pleural fluid? The function of the pleural fluid is to reduce the friction, right? To reduce the friction between the parietal pleura and as well as the visceral pleura, right? That is one particular function. And the second important function of the pleural fluid is it acts as the shock absorber. Right? It acts as the shock absorber to the external injuries over the chest. That is the function of the pleural fluid. And if you see the quantity of the pleural fluid in a normal individual, the quantity of the pleural fluid in a normal individual, it is around 5 to 15 ml. Right? So 5 to 15 ml of the pleural fluid is present in the normal pleural space. Now the question is, where is this particular pleural fluid coming from? There is constant movement of the fluid from the parietal pleural capillaries into the pleural space. Okay. So within the parietal pleura, you have the parietal pleural capillaries. And from this parietal pleural capillaries, the fluid enters into the pleural space. And the fluid enters into the pleural space at a rate of 0.01 ml per kg. Right? The fluid enters into the pleural space at a rate of 0.01 ml per kg body weight. And the fluid which enters into the pleural space, it is absorbed through the lymphatics. So the fluid, it enters via the parietal pleural capillaries and it is absorbed via the lymphatics which is present within the parietal pleura. Alright, so this is the basic physiology, right, where the fluid is coming from. Then, what do you understand by the terminology, the pleural effusion then? In a normal individual, the quantity of the fluid should be around 5 to 15 ml. But in case of pleural effusion, there will be abnormal accumulation of the fluid in the pleural space. Right, there will be abnormal accumulation of the fluid in the pleural space. That is what you mean by the word the pleural effusion. Now, you need to understand the other important terminologies, that is, depending upon the substance which is accumulated in the pleural space, accordingly we give the terminology. For example, if it is just excessive amount of the fluid accumulated in the pleural space, we call it as the pleural effusion. And we have other terminologies called as empyema, and another important terminology is chylous effusion. What do you understand by this word empyema? See, accumulation of grossly purulent fluid in the pleural space is what is called as empyema. So, empyema, it is the accumulation of grossly purulent fluid in the pleural space. That is what is called as the empyema. Then, what do you understand by this word? The chylous effusion. Accumulation of milky white pleural fluid right, accumulation of milky white pleural fluid, right, accumulation of milky white pleural fluid in the pleural space, that is nothing but accumulation of excess quantity of lymph in the pleural fluid, that is what is called as the chylous effusion. Now, if you do the analysis of this particular chylous effusion, what is that the chylous effusion contain? See, the chylous effusion, it contains the presence of chylomicrons, right, and chylous effusion, it contains high levels of the triglycerides, right, high levels of triglycerides. And what should be the quantity of the triglycerides? That should be more than 100 milligrams per deciliter. Right, that should be more than 100 milligrams per deciliter. That is what you mean by the word chylous effusion. So, accumulation of lymph, that is the milky white pleural fluid in the pleural space, is called as the chylous effusion. And in the chylous effusion, you have the greater quantity of the chylomicrons and high triglyceride levels, and the triglycerides will be more than 100 milligrams per deciliter. Okay, so that is what you mean by this word chylous effusion. Now, another forms of effusion that can be there within the pleura is the hemorrhagic pleural effusion, and another important terminology what we have is the hemothorax. Now, what do you understand by this word hemorrhagic pleural effusion? See, hemorrhagic pleural effusion, it is the mixture of right, it is the mixture of blood and pleural fluid, right, mixture of blood and pleural fluid, that is what is called as the hemorrhagic pleural effusion. Now, for suppose if the number of RBCs are around, right, if the number of RBCs are around 10,000 red cells per microliter, right, if the number of RBCs are around 10,000 red cells per microliter, that will create a blood tinged pleural fluid. Right, that will create a blood tinged pleural fluid. Okay, and for suppose if the quantity of red cells are around 1 lakh per microliter, right, if the quantity of red cells are around 1 lakh red cells per microliter, then that will create a grossly bloody pleural fluid. Right, that will create grossly a bloody pleural fluid. That is what is called as the hemorrhagic pleural effusion. If it is like 10,000 cells per microliter, it gives you a blood tinged pleural fluid. If it is around 1 lakh per microliter, that will give you a grossly bloody pleural fluid. Then, what do you understand by this terminology? That is hemothorax. See, hemothorax is the presence of gross blood in the pleural space. Right, the presence of gross blood in the pleural space. Okay, so that is what is your hemothorax. Now, what is the etiology for your hemothorax? The etiology include number 1, chest trauma, or instrumentation. Right, chest trauma or instrumentation is the one which will be responsible for the development of the hemothorax. Now, we also have a criteria to call it as a hemothorax. It is defined as ratio of the pleural fluid hematocrit to peripheral blood hematocrit more than 0.5. Okay, so it is the ratio of pleural fluid hematocrit to peripheral blood hematocrit. Right, if this particular ratio, if it is greater than 0.5, right, if it is greater than 0.5, then we call it as the hemothorax. This is a criteria to call it as hemothorax, right? Now, let me discuss the pathophysiology of development of the pleural effusion. So, if you see the pathophysiology, okay, what is the basics that we have discussed? See, from the capillaries which are present in the parietal pleura, the fluid will enter into the pleural space, right? From the capillaries which are present in the parietal pleura, the fluid will enter into the pleural space, and the fluid is taken out by the lymphatics, right? The fluid is taken out by the lymphatics. All right, now what are those lymphatics which will absorb the fluid? That is your mediastinal lymphatics, costal lymphatics, and as well as the diaphragmatic lymphatics. These lymphatics, they will absorb the fluid from the pleural space, which is drained from the capillaries of the parietal pleura. So the fluid enters via capillaries in the parietal pleura and removed via lymphatics in the parietal pleura. Now, any condition right, any condition disturbing either of above two results in pleural effusion, right? Any condition right, any condition whichever is disturbing above two results in the development of the pleural effusion. Okay, so any condition disturbing the above two means what? For suppose, if excess amount of the fluid enters into the pleural space via capillaries in the parietal pleura, or if there is decreased absorption by the lymphatics, right, if there is decreased absorption by the lymphatics, then also that will contribute to the development of the pleural effusion. Now, accordingly, there are the following pathophysiological process that will account for your pleural effusion. Number one, right, the first one is increased production of the fluid in the setting of the normal capillaries, right, increased production of increased production of the fluid in the setting of the normal capillaries. Now, when there is increased production of fluid, subsequently there will be also increased hydrostatic pressure as well. Right, subsequently there will be increase in the hydrostatic pressure as well. That can contribute to the development of your pleural effusion. Okay, next, second pathophysiological process which will account for pleural effusion is increased production of the fluid due to abnormal capillary permeability. See, the first scenario is increased production of the fluid in the setting of normal capillaries. Right, in the setting of the normal capillaries. And second scenario is increased production of the fluid, right, increased production of the fluid due to abnormal capillary permeability. right, due to abnormal capillary permeability. So here what you have is exudative type of pleural effusion. I'll discuss the types of pleural effusion. I'll discuss transudative and as well as exudative. I will discuss. And the third important pathophysiological process for the development of pleural effusion is decreased lymphatic clearance of the fluid. Right? And this decreased lymphatic clearance of the fluid will also contribute to the development of the exudative type of pleural effusion. And the fourth important reason for the development of the pleural effusion is infections in the pleural space. Right, infections in the pleural space. Infections in the pleural space that will contribute to the development of empyema. Right, that will contribute to the development of empyema. And the fifth important pathophysiological process for the development of the pleural effusion is bleeding into the pleural space. Right, bleeding into the pleural space. And this bleeding into the pleural space, we call it as the hemothorax. So these are the various pathophysiological processes which will contribute to the development of the pleural effusion. Right? So these are the 5 pathophysiological processes. Now, let me tell you that the pleural effusion, it is of 2 types. One is exudative and the other one is transudative type of pleural effusion. Now, you take transudative type of pleural effusion. Transudative type of pleural effusion, this is also called as the hydrothorax. Right? This is also called as hydrothorax. Now, let me explain you why there will be development of transudative type of pleural effusion. First of all, okay, so you consider this is the pulmonary capillary. Right? This is the pulmonary capillary. Right? So, in this capillary, hydrostatic pressure is equal to that of the oncotic pressure. Right? Hydrostatic pressure is equal to that of the oncotic pressure. And that is the reason why the fluid will stay within the vessel. Right? That is the reason why the fluid will stay within the vessel. Now, what will happen in transudative type of pleural effusion? Let me explain you. And first of all, in transudative type of pleural effusion, the capillary is absolutely normal. There is no pathology within the capillary endothelium or capillary at all. Right? And in a normal individual, okay, in a normal person, in any capillary, hydrostatic pressure is equal to oncotic pressure. That is the reason why the fluid will stay within the vessel. Now, okay, let me also explain you what is hydrostatic pressure and what is oncotic pressure. See, hydrostatic pressure, it is a positive pressure. What do you mean by that? It will push the fluid out. Right? It is a positive pressure. Right? It will push the fluid out. Whereas oncotic pressure, it is a negative pressure. Right? What it does, it will pull the fluid in. And hydrostatic pressure, it is due to the presence of the fluid in the vessel wall. Right? It is due to the presence of the fluid in the vessel. That will be your hydrostatic pressure. Whereas oncotic pressure, it is due to the presence of the plasma proteins. Right? It is due to the presence of the plasma proteins. That is what is your oncotic pressure. Oncotic pressure, what it will do, it will pull the fluid in. And in a normal person, in a vessel, the hydrostatic pressure will be equal to that of oncotic pressure. So the pressure which is pushing out the fluid and the pressure which is pulling the fluid inside will be equal. And that will result in the presence of the fluid within the vessel itself. There is no extravascular accumulation of the fluid in a normal person because both are equal. But in case of transudative type of pleural effusion, what will happen? In transudative type of pleural effusion, the hydrostatic pressure will be more than compared to that of the oncotic pressure. That means what? The positive pressure is more than compared to that of the negative pressure. So thereby what will happen? The fluid will move out of the vessel and the fluid will enter into the pleural space, resulting in pleural effusion. That is what will happen in case of the transudative type of pleural effusion. Like for example, you take in case of congestive heart failure. In case of congestive heart failure, what will happen to the transudative pressure, right? What will happen to the hydrostatic pressure within the vessel? The hydrostatic pressure is more because of the excessive accumulation of the fluid in the pulmonary capillaries, and that will contribute to the development of your pleural effusion. That is in transudate. Whereas you take exudative type of pleural effusion. In exudative type of pleural effusion, there is damage to the pulmonary capillary. Right, there is damage to the pulmonary capillary. Now, because of damage to the pulmonary capillary endothelium, what will happen is the plasma proteins, they move out, right? The plasma proteins, they move out. See, these are your plasma proteins, right? These are your plasma proteins. So the plasma proteins, they move out of the vessel. Now, plasma proteins, what do they exert? They exert the negative pressure. That means they pull the fluid. So similarly, the plasma proteins, when they are leaked out of the vessel due to the pulmonary capillary endothelial damage, these plasma proteins, what they do is, they pull the fluid outside the vessel, right? They pull the fluid outside the vessel, and that will result in what is called as the exudative type of pleural effusion. So, in exudative type of pleural effusion, the fluid is pulled out by the plasma proteins, right? That is what is the difference between transudative and as well as exudative type of pleural effusion. So one important difference, in transudative, the pulmonary capillary endothelium will be normal and hydrostatic pressure is increased, whereas in exudative, there is damage to your pulmonary capillary endothelium. And second important point, the plasma proteins which have leaked out of the vessel will pull the fluid out. That will result in the exudative type of pleural effusion. Okay. Now, next important, let me discuss the differences between transudative and as well as the exudative type of pleural effusion. So, you see this table. First of all, you should know what are the etiologies. In the sense, what is the basic pathophysiology? That already I have discussed just now. In transudative, it is mainly because of increase in the hydrostatic pressure then compared to that of the oncotic pressure, right? And this increase in hydrostatic pressure is because of excess accumulation of the fluid in the vessel. And what are the causes for that? That includes congestive heart failure, right? In congestive heart failure, there is excessive accumulation of the fluid in the pulmonary capillary. And because of that excessive accumulation of the fluid in the pulmonary capillary, there will be increase in hydrostatic pressure and thereby there will be extravasation of the fluid into the pleural space, resulting in the transudative type of pleural effusion. Whereas in exudative, the pathology is basically inflammation. Right, the pathology is basically the inflammation of the vessel wall, and this inflamed vessel wall, there will be damage to the capillary endothelium and there will be leakage of the plasma proteins, right? Leakage of the plasma proteins into the extravascular compartment, that is in the pleural space, and these plasma proteins will pull the fluid out from the vessel into the pleural space, resulting in exudative type of pleural effusion. So if you see the appearance of the fluid in transudative type of pleural effusion, the fluid is clear, whereas in exudative type of pleural effusion, the fluid, it is cloudy. Why is that? Because of the presence of the plasma proteins in the pleural fluid. And if you take the specific gravity in case of transudative, it is less than 1.012. Whereas in exudative, the specific gravity is slightly on the higher side, that is more than 1.020, right? More than 1.020. And if you take the protein content in transudative, it is less than 3 grams per liter, whereas in exudative type of pleural effusion, it is more than 3 grams per liter. And the fluid protein to the serum protein ratio, right? The fluid protein to the serum protein ratio, if you see, in transudative, ratio is less than 0.5. In exudative, it is more than 0.5, right? And the fluid LDH to the serum LDH, right? The ratio of fluid LDH to the serum LDH. In transudate, the ratio is less than 0.6, whereas in exudate, the ratio is more than 0.6, right? Ratio is more than 0.6. So, ratio is more than 0.6 or more than, right, or more than 2/3 of the upper limit of the serum. Right, more than 2/3 of the upper limit of the serum. So that will be your LDH. So these are the differences between transudative and as well as the exudative type of pleural effusion. Now, we need to understand a very important criteria in exudative type of pleural effusion, that is Light's criteria. So, what is this Light's criteria? Light's criteria is that where you have the exudative type of pleural effusion within the individual, and these three features should be there. That is, the pleural fluid protein should be more than 3 grams per liter, and fluid protein to serum protein ratio should be more than 0.5, and the fluid LDH to the serum LDH is more than 0.6. So, if these three are there, then that constitutes the Light's criteria, and that is suggestive of the exudative type of pleural effusion, right? Now, having discussed about the differences between transudative and as well as exudative, let me discuss the etiology of the pleural effusion. So the question is, which of the following conditions may lead to exudative pleural effusion? Right, which of the following conditions may lead to exudative type of pleural effusion? Right, let me discuss the etiologies of exudative and as well as the transudative. First of all, the options are cirrhosis, nephrotic syndrome, congestive heart failure, bronchogenic carcinoma, right? So first I'll discuss the etiologies and then come back to this question again. So if you take the exudative causes, we have neoplastic diseases, and that particular neoplastic diseases include bronchogenic carcinoma, right, bronchogenic carcinoma, then mesothelioma, then breast carcinoma, and next lymphoma. So these are the neoplastic diseases that contribute to the development of exudative type of pleural effusion. Then you take the infectious diseases. Infectious diseases, it includes the tuberculosis. So, and next to this tuberculosis, we have the pneumonias, that is bacterial, fungal, viral, or parasitic infections. Okay, so these are the infectious diseases which will contribute to the development of exudative type of pleural effusion. And collagen vascular diseases, that includes SLE, that is systemic lupus erythematosus, and then rheumatoid arthritis. Right, and then rheumatoid arthritis. And gastrointestinal diseases that contribute to the development of exudative type of pleural effusion is pancreatic disease, like mainly it contributes to your left-sided pleural effusion, and then diaphragmatic hernia. Okay, so these are the gastrointestinal causes for the development of exudative type of pleural effusion. Then next is the drugs. The drugs which will contribute to the development of exudative type of pleural effusion is nitrofurantoin. And this nitrofurantoin is the antibiotic used in the treatment of urinary tract infection. And then we have bromocriptine. Bromocriptine is the dopamine agonist. Then we have dantrolene sodium, and next amiodarone. Amiodarone, it is a class 3 antiarrhythmic drug used in the treatment of ventricular tachycardia, ventricular fibrillation, or even atrial fibrillation. So these are the drugs which can contribute to the development of exudative type of pleural effusion. And we have another important syndrome, that is Meigs syndrome. And this Meigs syndrome, it is characterized by a triad. Right. Now, what does this triad constitutes? This triad, it constitutes ascites, 2, exudative type of pleural effusion, and 3, ovarian fibroma. So these are the causes for exudative type of pleural effusion, right? Meigs syndrome is a gynecological disorder. Mainly the individual will have the starting with the ovarian fibroma, benign ovarian fibroma, and then subsequently the individual can have ascites and as well as pleural effusion. Then yellow nail syndrome. Now this yellow nail syndrome, it is a lymphatic disorder. It is a primary lymphedema. Right, it is a primary lymphedema associated with yellow nails and pleural effusion. And in these patients with the exudative type of pleural effusion, another important etiology is uremia. Right, this also can contribute to the exudative type of pleural effusion. So these are all the etiologies which cause exudative type of pleural effusion. And let me just give you, because there are many etiologies, right? So let me just give you a mnemonic for you to remember all these exudative type of pleural effusion. One of the very important etiology which will cause the exudative type of pleural effusion is tuberculosis. So the mnemonic is TB infection and miscellaneous. Right? This is the mnemonic for exudative type of pleural effusion. So T stands for tuberculosis, B is your bronchogenic carcinoma, and the word I stands for infarction, that is pulmonary infarction. N stands for pneumonia, that is the most common cause for exudative type of pleural effusion. F is your fistula, that is ventriculoperitoneal fistula. E stands for esophageal perforation or esophageal rupture. C is your collagen disease or post-CABG. T stands for trauma. I is your intra-abdominal abscess. O is your ovarian hyperstimulation syndrome. N stands for numerous drugs. And these drugs include amiodarone, which is an antiarrhythmic drug, nitrofurantoin, which is used in the treatment of urinary tract infection, and hydralazine, which is an arteriolar vasodilator. Cabergoline, it is a dopamine agonist used in the treatment of prolactinoma. And A stands for ARDS. M is your miscellaneous cause that includes the yellow nail syndrome and as well as the trapped lung. So these are the etiologies that contribute to the development of the exudative type of pleural effusion. Now, let me tell you what are the etiologies which will cause transudative type of pleural effusion. So, if you see this question here which we were discussing previously, which of the following may lead to the exudative type of pleural effusion? The answer is the bronchogenic carcinoma. Whereas, do you see pleural effusion in cirrhosis, nephrotic syndrome, congestive heart failure? Yes. You also see pleural effusion even in the following conditions as well. But the type of pleural effusion that you will see in these conditions will be transudative type of pleural effusion. Right, it will be transudative type of pleural effusion. Right, now let me discuss what are the etiologies which will cause transudative type of pleural effusion. The mnemonic for that is champion. First of all, you should know what is the most common cause for transudative type of pleural effusion. That is your CHF, congestive heart failure. And other causes for transudative include constrictive pericarditis, right? CP stands for constrictive pericarditis. H stands for hepatic cirrhosis. A stands for albumin being low, that is your hypoalbuminemia. M stands for myxedema. Right, and this particular myxedema is nothing but your hypothyroidism. P stands for peritoneal dialysis. Right, the word I, it is your iatrogenic causes. Right, iatrogenic causes. Right, what are those iatrogenic causes? That is extravascular migration of central venous catheter. The word O stands for obstruction of superior vena cava. Right, obstruction of superior vena cava or obstructive uropathy. N stands for nephrotic syndrome. So these are the transudative causes for the pleural effusion. Next, followed by that, let me tell you what are the causes for malignant pleural effusion. Right, and let me tell you what are the causes for bilateral pleural effusion. What are the causes for right-sided pleural effusion? What are the causes for left-sided pleural effusion? Right, and what are the causes for hemorrhagic pleural effusion? So in this way, we have many multiple choice questions on the topic of the pleural effusion. So first of all, the etiologies causing malignant pleural effusion. The etiologies causing malignant pleural effusion, that includes bronchogenic carcinoma. Right, bronchogenic carcinoma, and the other important, breast cancer can also contribute to the development of exudative type of pleural effusion. And the other common causes, as already just now we have discussed, that is mesothelioma and as well as lymphoma. But what is that I'll be adding at this point is malignant pleural effusion. What will be the appearance of the fluid? Appearance is it is turbid to bloody in nature. And if you take the glucose in malignant pleural effusion, it is less than 60 milligrams percentage. And if you take the cytology of malignant pleural effusion, that will show you the presence of abnormal cells. That is, that will show you the presence of the malignant cells. Right? That will show you the presence of the malignant cells. So that is what is your malignant pleural effusion. Next, you should know what are the causes for bilateral pleural effusion. So if you see the etiologies causing bilateral pleural effusion, that includes left ventricular failure, pulmonary infarction, hypoalbuminemia, and then malignancy. These are the causes for bilateral pleural effusion. Next, having discussed about this, let me just ask you a question on the transudative pleural effusion. See, etiologies, is it like you have to remember for the exam? Yes, because based on the etiology also you can have a question. Like for example, all of the following are causes of transudative type of pleural effusion except nephrotic syndrome, rheumatoid arthritis, constrictive pericarditis, and myxedema. So the answer is rheumatoid arthritis, because rheumatoid arthritis, it will cause rheumatoid pleuritis, where the individual will have exudative type of pleural effusion. Right, where the individual will have exudative type of pleural effusion. And the next important question is, what is the most common cause of pleural effusion? Most common cause of pleural effusion, the options are congestive cardiac failure, pulmonary tuberculosis, pneumonia, nephrotic syndrome. The answer is congestive cardiac failure. That is the most common cause of pleural effusion. Next, another important question is, what are the causes for left-sided pleural effusion? What are the causes for right-sided pleural effusion? See, the question can be asked in the following manner. Left-sided pleural effusion is seen in pancreatitis, rheumatoid arthritis, hypoproteinemia, congestive cardiac failure, esophageal rupture. So, if you take the causes for predominant left-sided pleural effusion, right, acute pancreatitis, and it is not difficult to remember also. Right, it is not difficult to remember. Why? Because your pancreas, it's a left-sided structure. So if there is any inflammation of the pancreas, that can contribute to your left-sided pleural effusion. And other etiologies are esophageal rupture, and then followed by that Dressler syndrome. Now, you should know what do you understand by this word Dressler syndrome. Dressler syndrome, it is a scenario where you have post myocardial infarction pericarditis. Right, it is a disorder where you have post myocardial infarction pericarditis. That is what is your Dressler syndrome. And what are the conditions where you have predominantly right-sided pleural effusion? You will have that in patients with amoebic liver abscess. Right, amoebic liver abscess. And second, cirrhosis of liver. Third, Meigs syndrome. Right, so these are the causes for predominant right-sided pleural effusion. Right, so if you go back to the question now again, left-sided pleural effusion is seen in pancreatitis and as well as the esophageal rupture. They will cause your left-sided pleural effusion. Whereas in congestive cardiac failure, you will have bilateral pleural effusion. Right, you will have bilateral pleural effusion in case of the congestive cardiac failure. Next, having discussed about the etiologies of pleural effusion, let me discuss what exactly will be the clinical features. Clinical feature is there will be development of gradual onset dyspnea. Right, there will be development of gradual onset dyspnea. Now, if you take this gradual onset dyspnea, why is that you will have gradual onset dyspnea? Because the excess amount of the pleural fluid which is accumulated in the pleural space, that will be compressing the lung parenchyma. And once this pleural fluid compresses the lung parenchyma, the exchange of gases does not occur. Right? The air from the alveoli does not enter into the pulmonary capillaries because of the fluid in the pleural space. And because there is impaired exchange of gases, that will make the individual to develop a gradual onset dyspnea. And other features are cough and chest pain. Right, cough and chest pain. Right, why is that the individual will have cough? Again, it depends upon the etiology. Like for example, if the pneumonia, tuberculosis, bronchogenic carcinoma, if these are responsible for the development of the pleural effusion, then the individual can have cough. And why there will be chest pain? That is because of pleurisy or pleuritis. Right, so there will be inflammation of, there will be inflammation of the pleura. So because of that, whenever the individual inhales or whenever the individual does the process of inspiration, there will be pain within the pleura, and that type of pain we call it as the pleuritic pain. See, it is what is a characteristic feature of the pleuritic pain? Number one, it is a pointed pain. That means what? You can pinpoint where exactly is the pain. And second important thing is, the pain will increase on inspiration. Right, the pain will increase on inspiration. So that is what you will have in case of pleuritis. The other important clinical manifestations completely depends upon the underlying etiology. Like for example, if the empyema is responsible for the pleural effusion, that is accumulation of pus in the pleural fluid, then the individual will have a very high grade fever. Right? So they will have systemic toxicity if the empyema is the cause for the development of the pleural effusion. Right? Now, having said this, you just see a question here. Which of the following is not a feature of an exudate? Proteins less than 3 grams, cells more than 1000 cells per cubic millimeter, cloudy appearance, cells predominantly are neutrophils. So the answer here is the proteins less than 3 grams is an incorrect statement. It is not a feature of exudate. Okay. So proteins, it should be more than 3 grams. Right, proteins, it should be more than 3 grams. Okay. Next, having discussed about that, let me tell you what will be the physical examination findings in patients with the pleural effusion. So, on inspection, what is that you will observe? See, there is pleural fluid in the pleural space. Because of the presence of the fluid in the pleural space, the chest expansion does not occur. So, there will be diminished chest wall movements. Right, there will be diminished chest wall movements. Why is that? That is because of the presence of the pleural fluid that will not allow the lung to expand. So there will be diminished chest wall movements. And second important thing is what will happen to your mediastinum. Mediastinum is shifted to the opposite side. So the trachea you will observe being shifted to the opposite side. Right, the trachea is seen on the opposite side. Next, third important thing is on palpation you will find that vocal phragmitis is reduced. Right, vocal phragmitis is reduced. And what will be the percussion note? Okay. So first of all, let me discuss about the vocal phragmitis. See, how do you check for the vocal phragmitis? you have to keep the ulnar aspect of the hand over the surface of the chest, and you should ask the individual to speak. The vibrations which are generated within the lung parenchyma are transmitted onto the surface of the chest, and that is being felt by the ulnar aspect of the hand, what you keep over the surface of the chest. But here, because of the presence of excess amount of the pleural fluid, the vibrations which are generated within the lung parenchyma are not adequately transmitted onto the surface of the chest. So thereby, what will happen to your vocal femmitus? The vocal femmitus will be decreased. And on percussion, you will have stony dull note. Right? On percussion, you have the presence of the stony dull note. And on auscultation, you have decreased breath sounds. Right? On auscultation, you have decreased breath sounds. Why? Because the fluid in the pleural space will not allow the breath sounds to be transmitted onto the surface of the chest. So the breath sounds will be reduced. So this will be the examination findings in patients with the pleural effusion. Now, we have a form of pleural effusion, or we have a clinical scenario which is called as the hydropneumothorax. Now, what do you understand by this word, the hydropneumothorax? Let me just show you the X-ray of this. So, this is the X-ray of the hydropneumothorax. So, in hydropneumothorax, as the word itself tells you, hydro means the fluid, and the word pneumo is air. So hydropneumothorax means the presence of fluid and as well as the air. Okay, that is what is called as hydropneumothorax. And in patients with hydropneumothorax, what does the chest X-ray shows? Chest X-ray, you have the presence of a horizontal line. Right, you have the presence of a horizontal line in hydropneumothorax. Now, these patients with hydropneumothorax, you have a characteristic auscultatory finding, and that is nothing but your succussion splash. Now, what do you mean by this succussion splash? Let me explain you. First of all, you should know that the succussion splash is present in hydropneumothorax. Okay, and in the chest X-ray, you have the presence of the horizontal fluid level. And how do you elicit this succussion splash? These patients with hydropneumothorax, what you have to do is, you have to catch hold of the individual anteriorly and posteriorly, and then you rigorously shake the individual. You need to rigorously move the individual, and then immediately you need to auscultate over the chest. When you immediately auscultate over the chest, you will listen the splashing sound. Okay, that is what is called as succussion splash. It is like similar, like for example, you take a half-filled bottle, right? A bottle with water which is half-filled, and then you shake that particular bottle. You will listen that particular splashing sound. The similar thing is your succussion splash also, which you will see in patients with the hydropneumothorax. Okay, so you see this question here. Which of the following is true about the pleural effusion? Horizontal fluid level, low lung volume, muffled heart sounds, decreased chest movements, and succussion splash. So the true statement in the pleural effusion is, they'll have low lung volume because the fluid in the pleural space will compress the lung parenchyma. They'll have muffled heart sounds, particularly in left-sided pleural effusion. You will have the presence of the muffled heart sounds, right? Because if it is left-sided pleural effusion, that too a massive pleural effusion, the heart sounds, they are not transmitted onto the surface of the chest. Thereby, you will have muffled heart sounds. And decreased chest wall movements will be there. But horizontal fluid level and as well as succussion splash, both of them, they are the features of the hydropneumothorax. See, hydropneumothorax and as well as pleural effusion, both are different clinical entities. Both are not same. Okay. Next, having discussed about this, let me discuss some of the very important etiology for pleural effusion that is the tuberculous pleural effusion. See, tuberculous pleural effusion is characterized by all except the options are hemorrhagic effusion, pleural fluid LDH more than 60% that of the serum LDH, increased deaminase, increased mesothelial cells. So, if you take the tuberculous pleural effusion, let me explain about tuberculous pleural effusion, then come back to this question. Tuberculous pleural effusion, it is one of the very important cause for it is one of the very important cause for exudative type of pleural effusion. And in tuberculous pleural effusion, the proteins are increased. And if you take the pleural LDH, the pleural LDH is increased. And the color of the fluid, it is either hemorrhagic or the straw colored fluid. Hemorrhagic or the straw colored fluid. And if you take the pleural fluid glucose, that will be equal to that of the serum glucose. The pleural fluid glucose will be equal to that of the serum glucose. And if you see the WBC count in the pleural fluid, it will be of lymphocytic predominance. It will be of lymphocytic predominance. And you have the high levels of the TB markers. Now, what are the TB markers? So, if you take these TB markers, that includes number 1, ADA, that is adenosine deaminase levels, they are elevated. That is more than 45 international units per liter. Okay, and interferon gamma, interferon gamma will be more than 140 picograms per ml. And another important tuberculous marker will be positive PCR for TB DNA. Positive PCR for TB DNA. So that will be your tubercular markers in the pleural effusion. So in tuberculous pleural effusion, you have exudative type of pleural effusion. Proteins are increased. The pleural fluid LDH is increased. Hemorrhagic pleural effusion will be there. The pleural fluid glucose will be equal to that of serum glucose. WBC counted is lymphocytic predominant, and you have high levels of the TB markers. ADA level is increased, interferon gamma is increased, and positive PCR for tubercular DNA. These are the features of the tuberculous pleural effusion. So going back to the question, tuberculous pleural effusion is characterized by all except hemorrhagic effusion, pleural fluid LDH more than 60% than that of the serum LDH, increased deaminase, increased mesothelial cells. So the answer is increased mesothelial cells. So where do you have this increased mesothelial cells? You will have that in bronchogenic carcinoma, or particularly specifically to tell in patients with mesothelioma. Mesothelioma, it is a tumor originating from the pleura. The remaining all you can have that in patients with the tuberculous pleural effusion. Next, followed by that, the another important question is, pleural fluid having low glucose is seen in all except the options are tuberculosis, empyema, mesothelioma, rheumatoid arthritis. Now, let me discuss what are all the conditions where you have the pleural fluid with low glucose. Here actually the answer is the tuberculosis, because already we have discussed. What did I tell you in case of tuberculosis? In tuberculosis, the pleural fluid glucose will be equal to that of the pleural fluid glucose will be equal to that of the serum glucose. Okay. Now, whereas in other conditions you have low glucose in the pleural fluid. Now, let me discuss all the conditions with low blood glucose or low pleural fluid glucose. Right? Conditions with low pleural fluid glucose. It is actually not blood glucose. Low pleural fluid glucose compared to that of the serum. Number one, in case of malignant pleural effusion, right? And this malignant pleural effusion, the examples are bronchogenic carcinoma, then breast carcinoma, next lymphoma, next the other condition is rheumatoid arthritis or rheumatoid effusion, third parapneumonic effusion, fourth hemothorax, next Church-Strauss syndrome, right? Church-Strauss syndrome, it is a small vessel vasculitis, right? It is a small vessel vasculitis. Then parasitic infection, that is paragonimiasis, right? These are all the conditions where you have the pleural fluid glucose less than compared to that of the blood glucose. So, in this question, what is the answer now? The answer is tuberculosis. Now, another question you see, low glucose in pleural effusion is seen in all except empyema, malignant pleural effusion, rheumatoid arthritis, Dressler syndrome. So, the first three you have low pleural fluid glucose. Whereas in Dressler syndrome, you will not have the low pleural fluid glucose. So, the answer is the Dressler syndrome. Now, another important set of questions that you need to know or you have to understand is about the amylase. So, the next question is, amylase increase in pleural fluid is seen in the following conditions except esophageal perforation, rheumatoid arthritis, malignancy, gallstone, pancreatitis. So, the conditions with high amylase levels in the pleural fluid include number one, esophageal rupture, and the second important etiology is pancreatic pleural effusion, right, which will contribute to high amylase in the pleural fluid, and third important is the malignancy of the lung. Okay, and what type of malignancy is that? It is the adenocarcinoma of the lung or the pancreatic carcinoma of the lung. So these are the conditions where you have the high amylase levels in the pleural fluid. So the question, if you see, amylase increase in pleural fluid is seen in all of the following except esophageal perforation, you will have increased amylase, malignancy, that is adenocarcinoma or pancreatic carcinoma, you will have high amylase, and even in pancreatitis or gallstone pancreatitis, you have high amylase. In rheumatoid arthritis, you will not have high amylase in the pleural fluid. Now, another important question that can be asked in your exams will be, what are the causes for hemorrhagic pleural effusion? The mnemonic is bleed to death. So definitely you have the blood in the pleural hemorrhagic pleural effusion. So the mnemonic, please remember, bleed to death. B stands for bronchogenic carcinoma. Right? B stands for bronchogenic carcinoma or the bleeding disorders. Right? Bronchogenic carcinoma or the bleeding disorders. And the word L will be your lymphoma. The word E will be embolism. That is pulmonary embolism. And the next E is extravasation. Right? And what extravasation is this? It is aneurysmal rupture. Right? Aneurysmal rupture can cause the extravasation of the blood into the pleural space, and that is nothing but your contribution to the development of hemorrhagic pleural effusion. And the word D is your disease, right? And what particular disease will cause hemorrhagic pleural effusion? That is SLE, that is systemic lupus erythematosus. And next is bleed to death. T stands for tuberculosis, right? You will have the hemorrhagic pleural effusion, or even trauma can contribute to the development of hemorrhagic pleural effusion. And the word D will be the drug overdose. Right? Drug overdose. And these particular drug overdose conditions where you will have hemorrhagic pleural effusion is warfarin overdose. Right? Warfarin overdose or anticoagulant overdose, that will contribute to your hemorrhagic pleural effusion. So these are all the conditions where you have the hemorrhagic pleural effusion. So the mnemonic, please remember, bleed to death. Next, another question is the presence of cholesterol crystals in the pleural effusion. Presence of cholesterol crystals in pleural effusion is a feature of myxedema, hypertriglyceridemia, hyperthyroidism, sarcoidosis. So please remember, the conditions where you have the cholesterol crystals in pleural effusion is in patients with hypothyroidism. See, in case of patients with hypothyroidism, there is dyslipidemias, right? There will be increase in the cholesterol levels. Right? There will be increase in the cholesterol levels. Now the question is why? See, thyroid hormone is the hormone which is required for lipolysis, which will break down the fat into free fatty acids. And when the thyroid levels are reduced, what will happen? The lipolysis does not occur. And because the lipolysis does not occur, there will be increase in the cholesterol levels in the pleural fluid. Okay, so not only in the pleural fluid, in the entire body there will be increase in the cholesterol levels, and that increased cholesterol within the body can get transported into the pleural space, resulting in hypercholesterolemia, that is increase in the cholesterol crystals in the pleural fluid. Next, the other conditions where you have the cholesterol crystals in the pleural effusion is the tuberculosis, and other conditions where you have cholesterol crystals in the pleural effusion is rheumatoid arthritis. Okay, so these are the conditions of pleural effusion with cholesterol crystals. And if you see this question now, presence of the cholesterol crystals in the pleural effusion is a feature of, the options are myxedema, hypertriglyceridemia, hyperthyroidism and sarcoidosis. So what will be your answer now? The answer will be myxedema, right, which is nothing but hypothyroidism. So don't be under the impression that hypertriglyceridemia will cause cholesterol crystals in pleural effusion. No. In hypertriglyceridemia, what you can have is increase in the triglycerides in the pleural fluid, right, but not increase in the cholesterol crystals. Okay, right. So having discussed about the cholesterol crystals in the pleural effusion, the next important thing you need to know about the pleural effusion is we have a clinical entity called as parapneumonic pleural effusion. What is this parapneumonic pleural effusion? It is the clinical condition where you have the presence of pleural effusion in the presence of pneumonia. So the individual has an underlying pneumonia, right? The individual has an underlying pneumonia. Upon that there is presence of the pleural effusion. Then we use the terminology called as parapneumonic pleural effusion. And we have three types of parapneumonic pleural effusion. Number one, simple or uncomplicated parapneumonic pleural effusion. Number two, complicated pleural effusion. Number three, empyema. These are the three types of or categories of the parapneumonic pleural effusion. Now let me discuss this uncomplicated parapneumonic effusion. See, uncomplicated parapneumonic effusion, it is the scenario where you have the presence of the sterile exudates in the fluid. right? Uncomplicated parapneumonic effusion, it is like a free flowing sterile exudate of modest size, and this uncomplicated parapneumonic pleural effusion, it will resolve quickly. Right, it will resolve quickly with antibiotic treatment. Okay, so that is what is your uncomplicated parapneumonic effusion. And this uncomplicated parapneumonic effusion, they do not need drainage. Right, they do not need the drainage. So that is your uncomplicated parapneumonic effusion. Then we have empyema. Empyema is gross infection of the pleural space. Right, gross infection of the pleural space, and this is indicated by the presence of gram positive or gram negative organisms within the culture. And this particular empyema, right, it should be evacuated by the tube thoracostomy. Right, it is evacuated by tube thoracostomy, and by doing this tube thoracostomy, the fluid clearance is being facilitated. Right, the fluid clearance is being facilitated. So that is about your empyema. And next we have the complicated parapneumonic effusion. So complicated parapneumonic effusion, it is the most difficult management. That is why it is complicated parapneumonic effusion. See, these complicated parapneumonic effusions, they are very large in size than compared to that of your uncomplicated parapneumonic effusion, right? And these complicated parapneumonic effusions, they show more evidence of the inflammatory stimuli. Right, they show more evidence of the inflammatory stimuli. And what is that evidence of the inflammatory stimuli? Such as low glucose level, low pH, and evidence of loculation. Right, evidence of loculation. So these are the features of the inflammatory stimuli, and that will be seen in complicated parapneumonic effusion, which is large than compared to that of your simple or uncomplicated parapneumonic effusion. Right, now having discussed about the parapneumonic effusion, let me just summarize all the types of the exudative type of pleural effusion. So let me just summarize all the types of the pleural effusion what we have discussed until now. So first of all, you take this malignant pleural effusion. Malignant pleural effusion, it is either turbid or bloody in appearance, and the number of cells, if you see, they are nearly around 1000 to 1 lakh cells per microliter, and RBCs, they are nearly around 100 to several hundred thousands of cells within the malignant pleural effusion. And glucose, if you see, it is equal to that of the serum glucose, or it might be less than that of the serum glucose as well, but most of the time it will be less than that of the serum glucose, and occasionally it can be equal to that of the serum glucose level as well. And if you take the cytological examination, that will give you the presence of the malignant cells or the mesothelial cells within the pleural fluid. Then if you see in case of the uncomplicated parapneumonic effusion, the gross appearance, it is clear to turbid in appearance, and the number of WBCs will be nearly around 5000 to 25,000 cells per microliter, and the RBCs will be less than 5000, and in uncomplicated parapneumonic effusion, the serum glucose will be equal to that of the pleural fluid glucose, and tube thoracostomy is not required in patients with uncomplicated pleural effusion. Then coming to your empyema. Empyema is nothing but completely pus, which is turbid to purulent in nature. And the number of cells like what you will see in empyema, it is nearly around 25,000 to 1 lakh cells per microliter, and the number of RBCs will be less than 5,000 cells per microliter, and if you take the pleural fluid glucose, it will be less than that of the serum glucose. And drainage, it is definitely necessary in patients with the empyema. Then followed by that, the tuberculosis. The gross appearance of the tuberculosis is either it is straw-colored fluid or the hemorrhagic in appearance. And the white cells, if you see, they are nearly around 5,000 to 10,000 cells per microliter. And RBCs will be less than 10,000 cells per microliter. And glucose will be equal to that of, the pleural fluid glucose will be equal to that of serum glucose most of the times. And the lymphocytic predominant is the characteristic feature that you will have in patients with tuberculous pleural effusion. Then followed by that, you take the rheumatoid effusion. Rheumatoid effusion, the appearance, it is turbid or greenish yellow in appearance. And the number of white cells, if you see, it is nearly around 1,000 to 20,000 cells per microliter. And RBCs are around less than 1,000 cells per microliter. And the pleural fluid glucose will be less than that of the serum glucose. And the other important points is there will be increased lactate dehydrogenase levels and as well as low complement levels, and rheumatoid factor also will be positive in the pleural fluid analysis. And then coming to your pleural infarction. So pleural infarction, the gross appearance, it is serous or grossly bloody in appearance, and the number of cells will be around 1,000 to 50,000 cells per microliter, that is your WBCs. And RBCs, if you see, 100 to more than 1 lakh RBCs will be there in case of the pulmonary infarction, and the pleural fluid glucose will be equal to that of the serum glucose. Then you take esophageal rupture. Esophageal rupture, mainly it is responsible for predominantly left-sided pleural effusion, and the gross appearance, it is turbid to purulent, and the number of WBCs, it is less than 5,000 or 2 more. So number of WBCs, it will be around 5,000 to 50,000 cells per microliter, and RBCs will be around 1,000 to 10,000, and the glucose is usually low, right? The pleural fluid glucose will be low than compared to that of the serum glucose. And in esophageal rupture, when you do a pleural fluid analysis, the amylase levels will be elevated. Then coming to your pancreatitis. See, in case of pancreatitis, the gross appearance, it is turbid or the serosanguinous. And WBCs, if you see, it is around 1,000 to 50,000 cells per microliter, and RBCs are around 1,000 to 10,000. And glucose, if you see, it is equal to that of the serum levels. And in pancreatitis, it is usually left-sided pleural effusion that you will have. So this is summary of the various types of pleural effusions what we have discussed. Now, having said this, let me discuss how do you diagnose this pleural effusion. See, investigation of choice will be chest X-ray, or first line investigation in case of the pleural effusion will be chest X-ray. Okay, so that will be your first line investigation. Now, what does the chest X-ray shows? Let me tell you, the earliest sign of pleural effusion on the chest X-ray will be blunting of costophrenic angle. Right, blunting of the costophrenic angle. So that will be the earliest sign in the chest X-ray in patients with the pleural effusion. Right, and what are the other features that you will have in X-ray of patients with the pleural effusion? There can be shift of the mediastinum to the opposite side, that is, the trachea is being shifted to the opposite side, and you have the presence of the homogeneous opacity. Right, you have the presence of the homogeneous opacity, and you have a characteristic curve that is called as Ellis S-shaped curve. Right, this particular curve, it is Ellis S-shaped curve. Okay, so these are the features on the chest X-ray in patients with the pleural effusion. Now, there are some important multiple choice questions related to your chest X-ray. Now, what are those? See, the question can be asked like, on a standard upright chest radiograph, what should be the minimal quantity of the fluid in the pleural space that is required to be visible on the lateral view. Okay, so the answer is the minimal quantity of the fluid that is required is around 75 to 100 ml of the pleural fluid must accumulate, right, must accumulate in posterior costophrenic sulcus. Right, must accumulate in the posterior costophrenic sulcus, and that will be visible on the lateral view. Right, that will be visible on the lateral view. And what should be the quantity of the fluid that should be present in the pleural space to have that pleural effusion on the frontal view? So the quantity of the fluid that is required is around 175 to 200 ml of the fluid should be there in the pleural space, right, should be there in the pleural space in the lateral costophrenic sulcus, right, in the lateral costophrenic sulcus to be appeared on the frontal view. These two are very, very important multiple choice questions, right? And whereas you take the CT scan, chest CT, what quantity of the fluid can be identified by the chest CT? Chest CT scan may identify as little as 10 ml of the fluid also, right, can identify as little as even 10 ml of the fluid as well. And the next important point is at least 1 centimeter of the fluid on the decubitus view is necessary to permit blind thoracentesis. See, what is thoracentesis? It is nothing but the aspiration of the fluid with the help of the pleural fluid needle or pluricentesis needle. So, for doing this particular thoracentesis or pluricentesis blindly, at least right, at least 1 centimeter of the fluid on decubitus view right, 1 centimeter of the fluid on the decubitus view is necessary to permit blind thoracentesis. Right, so these are some of the very important multiple choice questions related to your chest X-ray and as well as the CT scan. Now, we have a terminology called as massive pleural effusion. What do you understand by this word massive pleural effusion, or when will you call massive pleural effusion? There should be presence of opacification of entire hemithorax. There should be opacification right, opacification of entire hemothorax or hemithorax. Then we use the word massive pleural effusion. And where do you have this massive pleural effusion? You can have that in patients with bronchogenic carcinoma, right, or it may be seen even in tuberculosis as well. So these are the conditions where you have massive pleural effusion. Then you take the importance of ultrasonography. See, what is the use of ultrasonography? Ultrasonography increases the safety of thoracentesis. Right, it increases the safety of thoracentesis and should be incorporated routinely by the trained users. So that is about your ultrasonography. Now, at the same time, you should know what are the indications for thoracentesis or thoracentesis, which is also called pluricentesis. Number one, if there is presence of massive pleural effusion, right, if there is presence of massive pleural effusion causing dyspnea within the individual, right, that is an indication for your thoracentesis or pluricentesis. And the next important indication is for pleural fluid analysis. So for pleural fluid analysis, this will be your diagnostic thoracentesis. Right? This will be your diagnostic thoracentesis. Whereas in massive pleural effusion, the thoracentesis, what you are doing is therapeutic thoracentesis. Right? Therapeutic thoracentesis. So this is the indication for your thoracentesis. Next, you should know what are the indications for tube thoracostomy. See, what you will do in tube thoracostomy, you will directly instill the tube, right, and you will drain the fluid, right? The fluid is drained into the drainage container. What are the indications for tube thoracostomy? See, for suppose, if the individual is having complicated pleural effusion, right, if the individual is having complicated pleural effusion with pleural pH around 7.2, right, complicated pleural effusion with pleural pH around 7.2 and lactate dehydrogenase greater than 1000 units per liter. That is the indication for tube thoracostomy. Now, next important thing is when the presence of empyema or when there is presence of the complicated parapneumonic effusion, these are the indications where you have to do tube thoracostomy. Now, the next important question here is, what are the indications for fibrinolytic agents? See, whenever you are doing tube thoracostomy drainage of empyema, right, whenever you are doing tube thoracostomy drainage of empyema, right, or whenever you are doing tube thoracostomy drainage of complicated parapneumonic effusion, right, complicated parapneumonic effusion, in these scenarios, let me tell you, you have a limitation, right? So the tube drainage or tube thoracostomy in empyema or complicated parapneumonic effusion is frequently complicated by presence of loculations. Right, it is complicated by loculations, and because of the presence of loculations, that will prevent the adequate drainage of the fluid, right, that will prevent adequate drainage of the fluid. Okay, so in order to break these particular loculations, what we do is we will instill the intrapleural fibrinolytic agents, right, we will instill the intrapleural fibrinolytic agents. So once you instill the intrapleural fibrinolytic agents, that will break the loculations and that will improve the drainage. And this fibrinolytic agents, what you need to add is, it is not just only fibrinolytic agent, it should be a combination. It is a combination of, right, it is a combination of intrapleural plasminogen activator, right, it is a combination of intrapleural plasminogen activator. Along with this, you need to add an enzyme, and that is deoxyribonuclease. So this particular enzyme will catalyze the extracellular DNA. right, will catalyze the extracellular DNA and it degrades the biofilm formation within the pleural cavity, and this have been found to improve the clinical outcome of the individual. So it is not just installation of only fibrinolytic agent. Along with the tissue plasminogen activator, you also need to add this enzyme, that is deoxyribonuclease, right? That is an enzyme that catalyzes the extracellular DNA, right? So this is about the treatment of pleural effusion. And if you see some questions here, in adult patient with pleural effusion, most common site for pleurisynthesis is done by inserting the needle in 5th intercostal space in mid-clavicular line, 7th intercostal space in mid-axillary line, 2nd intercostal space adjacent to the sternum, 10th intercostal space adjacent to the vertebral column. The answer is 7th intercostal space in the mid-axillary line, right? So this should be the position of the patient whenever you are doing the pleurisynthesis, right? So the individual has to rest the arms over a couch or a table. And what is the use of resting the arms over the couch or table? That will help in increasing the intercostal space for the needle insertion. And always remember, where will you insert the needle within the intercostal space? That is upper border of upper border of the lower rib. So in the upper border of the lower rib, right, you need to insert the needle and you need to do the pleurisynthesis, right? So that is about in which intercostal space you need to insert the needle. That is 7th intercostal space in the mid-axillary line. Now let me just summarize the entire pleural effusion, right? For suppose, if you have a case of pleural effusion, what is that you have to do? You need to perform the diagnostic thoracentesis first, and then you need to measure the pleural fluid protein and as well as the LDH. Now, once you measure the pleural fluid protein in LDH, like for example, the pleural fluid protein to serum protein is like more than 0.5, and pleural fluid LDH to the serum LDH is more than 0.6, and pleural fluid LDH is more than 2/3 of the upper limit of normal. In this scenario, right, if all these criteria are present, or if any one of the criteria is present, that will diagnose the exudative type of pleural effusion. And if none of these criteria is there, then it is transudative type of pleural effusion. Now, for suppose, if it is an exudative type of pleural effusion, then what is the next thing you have to do? You have to measure the pleural fluid glucose, amylase, you need to obtain the pleural fluid cytology, and you also need to obtain the differential cell count, culture and staining of the pleural fluid, and pleural fluid marker for the tuberculosis. So you need to work upon all these on the exudate. Now, after having a workup of this, for suppose you found that amylase is elevated, then what will you suspect? Either it is esophageal rupture or pancreatitis or malignancy. And or suppose like you found that the glucose levels within the pleural fluid is less compared to that of the serum glucose, then you need to suspect either malignancy, infection or rheumatoid arthritis. Then, or for suppose you have done all the workup, right, there is no diagnosis, right, you did not come to a particular etiology, then what is that you need to do next? You need to consider pulmonary embolism and you have to do a spiral CT or the lung scan. For suppose you found that pulmonary embolism is there, treat for pulmonary embolism. And even upon doing the spiral CT or lung scan, the pulmonary embolism is not found. Then you have to test for the marker for tuberculosis. If the marker for tuberculosis, that is TB-PCR, is positive, then you treat for tuberculosis. And if it is not present, then you need to treat symptomatically, or you need to consider thoracoscopy or open pleural biopsy. That is how you have to analyze a patient with the pleural effusion, right? So workup is very important in order to make out what is the etiology of the pleural effusion. And accordingly, you see some clinical questions. A patient is having right-sided pleural effusion and on thoracentesis, the pleural fluid does not clot on standing. What is the possible cause? The options are Meeks syndrome, congestive heart failure, malignant pleural effusion, tuberculosis. So please remember, the pleural effusion of the congestive heart failure does not clot. So in congestive heart failure, what you will have is the transudate. Right? What you have is a transudate. So the pleural fluid that does not clot is a transudate. And only cause of transudate out of the 4 options which has been given to you is your congestive heart failure. Whereas your remaining options A, C, D, they contribute to your exudative type of pleural effusion. Right? They contribute to your exudative type of pleural effusion that will clot on long standing. Followed by that, which of the following conditions is managed with the tube thoracostomy with instillation of tissue plasminogen activator? Malignant pleural effusion, parapneumonic effusion, effusion secondary to pulmonary embolism, hemothorax. So just now we have discussed. So where is that we require to do tube thoracostomy and installation of the fibrinolytic agent? That is in clinical scenarios like empyema and in clinical scenarios like complicated parapneumonic effusion. So these are the conditions where you need to instill the tissue plasminogen activator. Right? Next. Now the next question is, therapeutic thoracentesis should be performed if the free fluid in the lung separates the chest wall by greater than. Right? Separates the chest wall by greater than 5 mm, 10 mm, 15 mm, 20 mm. The answer is 10 mm. Right? The answer is 10 mm. See, the possibility of parapneumonic effusion should be considered in the patients with bacterial pneumonia. And if the free fluid separates the lung from the chest wall by more than 10 mm, then you need to do this particular therapeutic thoracentesis. Now, let me tell you the indications of therapeutic thoracentesis. Number 1, loculated pleural effusion, pleural fluid pH less than 7.2, pleural fluid glucose less than 60 milligrams per deciliter, positive culture for the pleural fluid, and presence of gross pus. These are the factors indicating the need for a procedure more invasive than thoracentesis. Right? That means what will you do here? You will do tube thoracostomy. Right? You will do tube thoracostomy. So that is about the indications for your tube thoracostomy. So these are some of the questions and as well as the detailed explanation of the topic of pleural effusion. Thank you very much.